Good morning, everyone. Today's our topic of discussion is arterial supply of the heart. So what are the competencies here? Competency belongs to 22.5. Describe the coronary arteries under the following headings: origin, course, branches, distribution, and applied aspects. Learning objectives. At the end of class, you all should be able to describe and demonstrate the origin, course, and branches of coronary arteries. Describe anatomical basis of ischemic heart disease. Now the coronary circulation. It refers to the vessels that supply and drain the heart. Vessels, as you all know, it includes arterial supply and venous drainage. So today we are going to discuss about the arterial supply. Arterial supply of heart is by coronary arteries. Now, what do you mean by coronary here? You all are hearing about coronavirus these days. So something coronary is related like that due to the way they encircle the heart much like a crown. So coronary actually refers to crown. Okay, you can see how these coronary arteries are encircling the heart like a crown. Okay, you can see here this bush-like, crown-like. Coronary comes from the Latin word coronarius, meaning crown. And these coronary arteries, they are arising from a vessel and they are supplying the heart, which is also like a vessel. Because heart, you all know, by development, it arises or it develops from the two tubes, Okay, so fusion of the two tubes give rise to the development of heart. So heart is also a largest vessel actually, and this vessel is supplied by the vessels which are arising from ascending aorta. So coronary arteries are considered as the largest vasa vasorum of our body. They are called as vasa vasorum of the heart because heart is a modified blood vessel. So now we have two arteries, right coronary artery and left coronary artery. Anatomically, these arteries are not end arteries. They are not considered end arteries because they anastomose with each other by their trunks, branches and subdivisions or sub-branches, mostly at the pre-capillary level. But functionally, these are end arteries. Why? Because most of the anastomosis remain impervious. That means the anastomosis does not allow the blood to pass. Impervious we call it. That's why these arteries are anatomically not, they are anatomically the end arteries, but functionally they are end arteries. Okay, anatomically they are not the end arteries because they are forming anastomosis, but functionally because they are not allowing the blood to pass, they are impervious, so they are end arteries functionally. Okay. These arteries, coronary arteries, they originate from the ascending aorta immediately above the aortic valves from the aortic sinuses. Now what is that? You can see in this image, we have, this is ascending aorta, this is arch of aorta, and then descending thoracic aorta. From ascending aorta, which actually is arising from the heart itself, it has three dilatations here. These dilatations are called as aortic sinuses. Fine. So this ascending aorta has three aortic sinuses. One is this anterior aortic sinus, and behind posterior we have two, right posterior and left posterior aortic sinus. Okay, so your one artery, the right coronary artery, arises from anterior aortic sinus, left coronary artery arises from left posterior aortic sinus. That's why these two are coronary sinuses, whereas the right posterior is called as non-coronary sinus because there is no any artery arising from right posterior aortic sinus. In this image, we can see again the ascending aorta, the aortic sinuses here. If you cut open this, you will see this image. This is your opened interior aspect of ascending aorta, where you can see these flaps. These flaps are actually the cusps. Okay, and above the cusp, this space is called as sinuses. Okay, so above the sinuses we have origin of these arteries. You can see the opening of the coronary arteries. This is anterior aortic sinus, so this would be your right coronary artery. This is left posterior aortic sinus, so this is your left coronary artery. These are called as ostium, coronary ostium. Okay, and this is non-coronary sinus. Again, if you do the section like this, transverse section, so you will find these sinuses, cusp. Above the cusp we have these sinuses. Okay, and here these are the origin of your arteries or coronary ostium. These are coronary ostium. This is the 3D image of ascending aorta. You can see how directed these sinuses are. And from one of the sinus, this is actually the anterior aortic sinus, where we have origin of right coronary artery. I hope the concept is clear here. This is again the opening part of ascending aorta. You can see the opened part here. These are the cusp. Here above this is sinus, so anterior aortic sinus, right posterior aortic sinus, and this is left posterior aortic sinus. From this you can see left coronary artery arising, ostium, coronary artery ostium, but here the right coronary artery ostium is there in the left posterior aortic sinus only. This is one of the variation. Or in the coronary artery origin, there can be n number of variations. Mostly what we are seeing commonly, that we are discussing in our books and in our lectures, but there can be n number of variations which you can find out in your dissection also. Coming to the each artery one by one. So we have right coronary artery now. Arises from anterior aortic sinus of the ascending aorta, as I already mentioned you. Course. The right coronary artery, it arises from ascending aorta, anterior aortic sinus, then it runs downwards and laterally in between, in the groove, this groove. This is called as, you have done with the external features of heart. I hope you all know the grooves and the contents. So in between, this is anterior part of atrioventricular groove. So first it runs downwards and laterally between the right auricle and pulmonary trunk. So this is actually your right auricle. Okay, this is right atrium. This part is called as auricle, flap like, and this is your pulmonary trunk. So first it runs between the right auricle and pulmonary trunk, then it runs downwards and then winds round. It winds round the inferior border. This is called as inferior border of heart. So it winds round the inferior border of heart, then runs in the posterior part of atrioventricular groove till it reaches a point called as crux of the heart. So this is a posterior aspect of the heart. Here the artery has turned around after running. This is your right atrium, right ventricle, right atrioventricular groove, posterior part. So now the artery has turned here and it is coming up to a point, this point where there is meeting of right atrioventricular groove, left atrioventricular groove, and interventricular sulcus and interatrial sulcus. This area is point, actually exact point, called as crux of the heart. Okay, meeting point of 4 grooves here. So mostly this right coronary artery ends at this point of crux of the heart. It gives a branch, the terminal branch, the largest branch, which is running in the posterior interventricular groove, called as posterior interventricular artery, and then it goes towards the left side and where it terminates by anastomosing with the branches of left coronary artery, usually the circumflex branch of left coronary artery. Now, what are the branches? For theoretical purpose, we can divide the right coronary artery into 2 segments, first segment and second segment. So from the origin up to this point, up to the inferior border, we call it segment 1, and on the posterior aspect up to its termination here, up to the crux of heart, you can say, this is called as segment 2 or second segment. Now branches from the first segment. As such, from this first segment, you can see one artery here going towards the infundibulum, this part of the this pulmonary trunk, which is arising from right ventricle here. You can see this conical funnel shaped structure. This is called as infundibulum. So the branches from first segment are right conus artery, right anterior interventricular artery, right conus artery, right anterior ventricular rami, and atrial rami. We have three branches from the first segment. So these are all this is right first segment actually, from where we have these atrial and ventricular rami and conus artery. Okay, from the segment 2, we'll be having other branches, posterior ventricular rami, we call it right posterior ventricular rami, and posterior interventricular artery. So we'll discuss now one by one. Segment 1. Now coming to right anterior ventricular rami. So right coronary artery gives another branches to supply the ventricles. There are 3 to 4 in number, and they supply the anterior surface of right ventricle. Mostly the right ventricle, they are called as anterior ventricular rami, and one of its branch is longest ventricular ramus. It runs along the inferior border of heart or along the right margin of the right ventricle. This is called as right marginal artery. These are all anterior ventricular rami. One of the branch is longest, running along the inferior border. Okay, so we have conus artery, conus branch of right coronary artery. We have ventricular rami. They're called as right anterior ventricular rami. And we have right atrial rami to supply the atrium. We can see here the major part of atrium will be supplied by this branch. Now this atrial rami, they give in 60 to 65% of subjects. One of the very important branch which will supply SA node called as sinoatrial nodal artery. SA nodal artery or sinoatrial nodal artery, which in 60 to 65% of cases is a branch from right coronary artery. In 30 to 35% of cases, it may arise from circumflex artery, which is a branch from left coronary artery. So SA node in majority cases will be supplied by right coronary artery through the atrial rami. So we can see here, this is your right coronary artery. From this, one of the branch is going towards this side. Now in this image, I can show you clearly, this is your anterior aortic sinus, this is ascending aorta. Fine, this is anterior aortic sinus, right posterior, left posterior aortic sinus. You can see the coronary ostium. So this is a right coronary artery. After coming out, it is giving a branch which is running between the ascending aorta and aortic right atrium or right auricle, and then it is passing medial to this superior vena cava, and then behind the superior vena cava it turns around and then it reaches up to SA node. So by this time you must be knowing what is the conducting system of the heart and where is the SA node and AV node located. So this is the SA nodal artery. In 60 to 65% of cases, I am repeating again, it is a branch from right coronary artery. Now second segment of right coronary artery. As you know, second segment gives the ventricular rami for the posterior surface of right ventricle. So right posterior ventricular rami, and one important branch here before its termination, last branch running in the posterior interventricular groove called as posterior interventricular artery. This posterior interventricular artery arises near the crux of heart, mostly in 70% of cases. It runs in the groove, and you must be knowing till now all the grooves and their contents. So you should know, it should be in your tip of tongue, what are the contents of anterior interventricular groove, posterior interventricular groove, right atrioventricular sulci, left atrioventricular sulci, anterior part, posterior part. You should be knowing all the contents. So here it runs in the posterior interventricular groove, where it is accompanied by this middle cardiac vein. And here it ends near the apex. Near the apex, it ends by anastomosing with anterior interventricular branch of left coronary artery. Okay, so this is your posterior interventricular artery. Here it ends by anastomosing with anterior interventricular artery. In 10% of subjects, this posterior interventricular artery may arise as a direct branch of left coronary artery. Now what it supplies, this posterior interventricular artery, through this ventricular branches here, it is supplying the adjacent parts of two ventricles, diaphragmatic surface of two ventricles, right ventricle and left ventricle. Also, posterior interventricular artery gives a very important septal rami, which will supply posto-inferior 1/3 of the interventricular septum. So interventricular septum has dual supply, both by the left coronary artery as well as right coronary artery. So posto-inferior 1/3 of the interventricular septum will be by right coronary artery through its septal rami from posterior interventricular artery. Okay, so this is a specimen here. You can see the right coronary artery. This is your posterior interventricular branch. This septal rami, now the septal rami from the posterior interventricular artery, it supplies septum, posterior 1/3. In addition, this artery forms a loop and supply AV node in 80 to 90% of cases. So in 80 to 90% of cases, AV node is supplied by right coronary artery. In only 10% of cases or 10 to 20% of cases, when it is not supplied by right, it will be supplied by a branch from left coronary artery. This is the diagram to show you just a revision how you can see the SA node location and AV node location. So that's why they are more towards the right wall only. So SA node as well as AV node, both in majority of cases are supplied by right coronary artery. But you should know the percentages also, in what percent of cases right and left artery supplying. Coming to left coronary artery. So we are done with the two segments of right coronary artery. In left coronary artery, we are not dividing it into segment. It is simple. Okay. Left coronary artery, from where it arises, you all know now. Left posterior aortic sinus of the ascending aorta. Okay, sinuses, you can see this is your left coronary artery. As such, this left coronary artery is very shorter. The trunk is very short and soon it divides into its branches. And it has larger and wider caliber than right coronary artery. Course. This is a trunk, very short trunk. As soon as it arises, it passes behind the pulmonary trunk. This is your pulmonary trunk here. It passes behind the pulmonary trunk. Then soon after, it divides into two divisions. Okay, so first it runs in between the pulmonary trunk and left auricle. This is your left auricle. And then it divides into one branch going downwards anteriorly, and it is arising from left coronary artery, so it is called as left anterior descending artery, or it is running in the anterior interventricular groove, so it is called as left anterior interventricular artery. And another one, it is encircling the heart towards the left side, so it is called as circumflex artery, left circumflex artery or circumflex artery. Okay, it is encircling the left atrium and left ventricle and going towards the posterior side, on the posterior aspect. So anterior interventricular artery or left anterior descending artery. So left coronary artery is this one. It gives anterior descending. We call it LAD, 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 left anterior descending. This runs in the anterior interventricular groove on the sternocostal surface, along with which vein? What is this vein here called as? Great cardiac vein. So again, the contents of anterior interventricular groove. Okay, it runs downwards towards the apex. Near the apex, it winds round the apex. That part is called as incisura apices cordis. You must have read in the external features. Then it turns on the back side. Already I told you, where it ends on the inferior surface or diaphragmatic surface by anastomosing with the posterior interventricular artery. Okay, again the same image. This is your posterior interventricular artery. This is the turned part of anterior interventricular artery or LAD, left anterior descending. Both are anastomosing here and terminating. Fine. So this is the course of anterior interventricular artery or left anterior descending artery. Now, what are the branches of anterior interventricular artery? This artery gives ventricular rami, and because it has to supply the anterior surface, so anterior ventricular rami, they are called as anterior ventricular rami to supply the anterior surface of left ventricle mainly and also the adjacent part of right ventricle. One of its ventricular rami, one of the branch is larger, and then it is called as diagonal artery. Okay, you can see here this one. One of the branch from left anterior descending may be large, not always, but may be large. When it is large, it is running diagonally, and then it is called as, or it is arising directly at the junction of, and directly from the left coronary artery at its junction of the circumflex and anterior descending. Left anterior descending and circumflex artery at their junction, one more artery. Actually, it is a branch from anterior interventricular artery, but it may arise directly from the left coronary artery. At that time, we call it trifurcation of left coronary artery. Okay, so this is your diagonal artery. Anterior interventricular artery, because it is running in the interventricular groove, it gives a septal rami. This septal rami, number of branches, they will supply the anterosuperior 2/3 of the interventricular septum. Now posterior 1/3 was supplied by posterior interventricular artery by septal rami. Anterior 2/3 of the interventricular septum is supplied by the septal rami from anterior interventricular artery or left anterior descending artery. Fine. Now coming to next branch, circumflex artery. It's a continuation of left coronary artery. You can see here running in the anterior part of left atrioventricular groove first. Then it winds round along the groove and reaches into the posterior part of the atrioventricular groove. So here, this is your circumflex artery. This is the coronary sinus actually. Okay, so tributaries of the coronary sinus are all there accompanying these arteries. It ends by anastomosing with the right coronary artery to the left of the crux. This is your right coronary artery. Here it is giving posterior interventricular artery. After that, as I told you earlier, it is going towards the left. This is the crux. So towards the left, they anastomose with the circumflex artery. Fine, we can see here. This is the anastomosis here. Now branches. Circumflex artery has to supply atria and ventricle. So it gives atrial rami and ventricular rami to supply the adjacent surfaces of left atrium and left ventricle. We can see atrial rami, ventricular rami. Now, as I told earlier, 30 to 35% of cases, one of the branch from circumflex artery will supply SA node. And one of its ventricular rami towards the left border, towards this border, is larger, and then it is called as left marginal artery, and it gives posterior interventricular artery in 10 to 20% of cases, as I mentioned you earlier. So coming to one by one, SA nodal artery. In majority of cases, SA nodal artery is a branch from atrial rami from the right coronary artery. But in 30% cases, 30 to 35% of cases, it may arise from circumflex artery, branch of left coronary artery. That you have to remember. Now, one of its branch from the circumflex, this is anterior descending, this is circumflex. One of the branch from circumflex runs along the left border of the heart, a larger branch. It is called as left marginal. Here was a right marginal artery, which was a branch from ventricular, one of the ventricular MI. Here's from one of the branch from circumflex artery runs along the left margin of the heart, left border of the heart, left marginal artery, also called as obtuse marginal artery. This one. Okay, we can see here, this is which artery? This one is diagonal artery from anterior interventricular or directly from coronary artery. This artery here, which is running along the left margin of the heart, this is called as left marginal artery or obtuse marginal artery. This artery is important, obtuse marginal artery, because in coronary artery bypass surgeries, a vascular autograft is anastomosed with this artery distal to its obstruction. This already I mentioned you in while discussing the internal thoracic artery. So internal thoracic artery is commonly used as a graft. So here for the heart, anterior, left anterior descending and this obtuse marginal arteries are commonly used in coronary artery bypass grafts. I hope everything is clear till now. Now another branch from circumflex artery. So we are done with atrial rami, ventricular rami, SA nodal artery. Now next is posterior interventricular artery in 10 to 20% of cases. Now this is very important concept here. Coronary predominance we call it. So actually this origin of posterior interventricular artery decides the coronary dominance or coronary predominance of a heart of a person. In 10 to 20% of cases, this artery arises from left coronary artery or as a branch from left circumflex artery, as a continuation of circumflex artery. So this type of heart will be actually showing left coronary predominance. We call it left coronary predominance. You can see here, this is a circumflex artery continuing as posterior interventricular artery. So now this right coronary artery is shorter, ending here, but the artery here in the posterior interventricular groove is also by the left coronary artery as a continuation of left coronary artery. You can see this is circumflex ending here, left coronary artery or circumflex branch continuing in the posterior interventricular groove. Now in this case, posterior interventricular groove will supply the posterior 1/3 of the interventricular septum will also be supplied by this artery, which is coming from left coronary artery. That means whole of the interventricular septum will be now supplied by left coronary artery, and the septal rami from here, which is normally coming from right coronary artery, which is giving a branch to AV node, I told you, in 80% cases. But in these percent of cases, septal rami will arise from left coronary artery. So this will give branch to AV node. So in these cases, AV node is usually supplied by left coronary artery from its septal branch. Sorry, AV node in 90% of cases and SA node in 60 to 65% of cases, right? Left coronary artery supplies left atrium, most of the left atrium, most of the left ventricle except a strip along the posterior and inferior surface of heart, anterior 2/3 of interventricular septum, AV node and SA node if they are not supplied by, or in the cases of variation, if they are not supplied by right coronary artery. This is the diagram showing your ventricles, the cavities here, and you can see this is your anterior interventricular branch. Left anterior descending we call it, posterior interventricular branch. Posterior 1/3 of the interventricular septum, anterior 2/3 of the interventricular septum are supplied by the septal rami. So anterior 2/3 will be supplied by left coronary artery, posterior 1/3 is supplied by right coronary artery. This is very important diagram. This you can show while in the arterial supply of the interventricular septum. You can draw this diagram. Coronary dominance, as I mentioned earlier, it depends upon from where the posterior interventricular artery is arising. Mostly it is right dominance, more common, where posterior interventricular artery is a branch from right coronary artery. But left dominance when posterior interventricular artery is a direct continuation of left coronary artery or circumflex branch of left coronary artery. Sometimes it's a balanced dominance. That means it arises from both, rarely arises from both. Then it is called as balanced. I hope you are clear with the concept of arterial supply of heart. Now we are coming to applied aspects. Very important here, ischemic heart disease. Due to occlusion of the coronary arteries or its branches, there can be ischemia, loss of blood supply to the portion of the muscle of the heart. Primary cause being the atheromatous plaque formation. There will be formation of some plaques in the wall of the arteries leading to narrowing of the lumen, followed by thrombus formation and narrowing. This narrowing can be gradual or sudden, and it can be complete or incomplete. Okay, you can see here, this is actually a complete chapter you will find in formation of atheroma. What are the factors leading to formation of these plaques, atheromatous plaque? When it is forming in the wall, there are changes in the wall. Number of factors are responsible leading to this. So this is a pathological thing actually leading to narrowing of the lumen. You can see how now because of so much of blood is coming, but less blood is passing forward. So ultimately, the area which is supplied by this narrowed artery will get less blood supply, right? And because of that, it will have less amount of oxygen, right? So decreased oxygen to the cardiac muscle, and this leads to anaerobic metabolism. There will be more of lactic acid and there will be decreased pH, and this leads to pain receptors which are present in the heart. They get stimulated by this lactic acid, and ultimately there will be increased pain, especially during doing some exercises when there more oxygen is required. Okay, so ultimately this leads to chest pain. Pain in the precordium. Precordium means the chest covering your heart is called as precordium. So incomplete obstruction usually leads to decreased blood supply, decreased oxygenation, particularly when the person is doing exercise or some vigorous activity where the demand of the oxygen in the body or in the heart is increased, and because of increased pumping activity requires more oxygen and blood vessels are already narrowed down, so it cannot supply it properly, and it leads to chest pain. It leads to chest pain, and this type of pain is actually acute and aggravated by some factors like during doing some exercise or some rigorous activities. Okay, so and that type of pain is called as angina pectoris. Angina means pain, pectoris means chest wall. Angina pectoris. It is a type of temporary chest pain or pressure or discomfort in the chest. Okay, now most common artery which is involved or which is occluded usually by the atheroma is left anterior descending artery in 40 to 50% of cases, followed by right coronary artery and then circumflex artery. Now this angina pectoris may have the most common symptom is chest discomfort, pressure or tightness or some burning sensation, chest pain, breathlessness. Okay, and this pain may be referred to other sites like epigastrium, shoulders or arm, neck or jaw, and may be associated with nausea and vomiting also. Most likely the sites of the referred pain are left arm and forearm, left shoulder and neck, and epigastrium. Now why left actually? Because they say uh, mostly left anterior descending is the artery which is involved in atherosclerosis, and 2/3 of the part of the heart is present on left side. As location, you must have seen the location. So muscles of left part of the heart is involved. So that's why the referred pain is more towards the left side. But if right part of the heart, suppose right coronary artery is involved, then pain will be more on the right side. So it is a myth or wrong concept or wrong notion, we can say, that cardiac pain is always referred to the left side. It can be on the right side depending upon which artery is involved. So if the pain is related to heart, if you are a physician and you are thinking the pain is towards related to heart, then you should go for angiography. Okay, so that to make out the exact location. If it is right radiating pain, then also it can be because of the coronary atherosclerosis, and depending upon other factors, definitely the history, detailed history you have to take. Now it can go to epigastrium. What is epigastrium actually? Where a xiphoid process is present in between your chest margins, no? Right and left chest margins here. So epigastrium, this part, this area. Why here actually? Because heart is involved. Then heart has pericardium, fibrous pericardium. As I told you earlier, pain is related to fibrous pericardium. So irritation of fibrous pericardium will, and this fibrous pericardium and lesser omentum and diaphragm, part of diaphragm, they have same origin. So same innervation, septum transversum, right? So epigastrium. That's why the pain will go to epigastrium also. Fine. Now, because if the occlusion is complete and sudden, it leads to ultimately loss of blood supply and ischemia of a particular area of the heart, that is called as myocardial infarction. The symptoms will be more aggressive. They can be low-grade fever also, nausea, vomiting, heartburn, abdominal pain, shortness of breath, cold sweat, lightheadedness, palpitations, abnormalities in heart rate or blood pressure. So more severe condition is actually the myocardial infarction. Diagnosis is actually made by coronary angiography, which is gold standard for detecting clinically significant atherosclerotic coronary artery disease. Okay, you can see this is coronary angiogram, which you can see this is a heart actually, where and the dye is going into these arteries. This is showing the coronary tree, you can say the coronary arteries pattern here. Coronary angiogram, more clear picture here. With the beating of heart, you can see how the arteries are also moving. And here in one side, you can see there's obstruction. Fine, on the left coronary artery. What are the goals of angiography here? Coronary angiography to visualize the coronary branches, collaterals and anomalies. Precise localization relative to major and minor side branches, thrombi and areas of calcification, and to visualize vessel bifurcations, origin of side branches and specific lesion characteristics. Okay, I hope you understood everything about the arterial supply and related aspects, applied aspects to the arterial supply of the heart. And please open your books now and read this topic again, because arterial supply, as such, the blood supply of heart can come as a long question. This is very, very, very important topic. Not only theoretically, clinically also, it's very important to understand what is actually supplying your heart. If you know the normal, you can make out abnormal, as I already always tell to you in the class also. Okay, thank you, have a nice day.